So good morning everybody, thanks for staying and coming to our Science Sunday. It's the second Sunday of every month we have this after coffee break. And so if you want to give us a Science Sunday talk, let us know, because we're keeping a good program going. So today we are welcome to have Paul Grundy. So he's going to talk about healthcare around the world. Paul, a bit of history, he's a physician. He's godfather of patient-central medical home. Thank you. The godfather of patient-central medical home. He's the son of Quaker missionaries, born in West Africa, or you lived in West Africa when you were a child. Went to medical school at the University of California, San Francisco. Did a master's in public health at UC Berkeley. He did John Hopkins for your residency, right? The medical officer, the U.S. Air Force, got Defense Ministry's Service Medal, U.S. Department of State. He helped work on the Clinton-Yeltsin Health Initiative between the USA and Russia, U.S. policy setting up for HIV/AIDS in Africa policy, and was awarded an award from the Queen of Denmark for setting up the Danish healthcare system. So please welcome our own Paul Grundy. Thank you.
Thank you. Well, thank you all for staying on the beautiful day. So just talk a little bit about kind of how we got to our healthcare delivery system in comparison to healthcare systems as they've evolved around the world. Our healthcare delivery system really starts as a system of care, if you call it a system, with a guy named Flexner. In 1910, he wrote a report called the Flexner Report, which standardized the education and training of our physicians. Up until then, you could be a surgeon by going to a barber school, and we had great variety of care in terms of the standard of care. Flexner looked at the German model of care and designed and developed a model of care in which the medical schools were licensed to issue a terminal degree, i.e. a doctor of medicine. So you needed an undergraduate degree, and then you needed 4 years of training as a physician. And then the whole concept of residency training was really started with that, i.e. you should be able at the end of your residency, if your attending dies, to take over and manage the case as well as your resident. So that's how our system evolved in 1910. By the way, 94 of the medical schools at the time closed with that Flexner report. None of them were. Very few were well enough. And the first model medical school designed after that report was Hopkins and University of Rochester in New York. So I retired from the Foreign Service, where I was a minister counselor for scientific and medical affairs, the interface between health policy and foreign policy, in the early 2000s. And I went to become the director of IBM as their medical director. By 2005, if you look at this slide, we were dead last in terms of the quality of care that we provided to our citizens. The quality, in essence, being life expectancy, infant mortality, the numerators that really define quality of care. And we were twice as expensive as any other care system in the world. At that time, my boss, the CEO of IBM, almost died of a drug-drug interaction. We have evolved out of the Flexner model. We've evolved really good specialty care. People, the Yakuza from Japan, come here to get their kidney transplants. So if you need something high-end, the chances are, if you have the insurance or you have the money, you can get good high-end care. But my boss almost died of a drug-drug interaction. He had 5 specialists without any adult supervision, right? And so, they didn't know what the other ones were prescribing. So my boss called me into his office, and he said, we need to buy something different than we're buying for our employees. And so that led me to pull together 47 of the Fortune 100 companies in the United States to then demand of our healthcare insurance plans that they change what they buy. And we created a model of care called a medical home, a concept of everybody having a primary care provider and we'll get into that a long way. But we really did a deep dive on what healthcare systems delivered of value to their citizens around the world. And there's really three models of care that have evolved over the past 100 or so years. The first model I'll talk about is known as the Beveridge model, and it's named after a guy named Lord Beveridge. It comes out of the English experience and the Second World War for the Scandinavian countries and England. They were devastated, right? I mean, they were bombed to smithereens. They had very little money. And so the only real institution that could stand up, run, and maintain a hospital delivery system was government. So Lord Beveridge passed legislation in 1947, which was created the National Health Service. The National Health Service is a system of care in which the government owns and runs the hospitals, right? The people who work for the hospitals are paid and salaried by government. That system of care was also developed in the other Scandinavian countries. So this system of care we also have in the United States. It's called the Veterans Administration. And when I surveyed my employees back in 2005, asking them how happy they were with the care that was provided through United, through Cigna, or 32,000 of our employees who had care through the Veterans Administration because they were eligible for that. Those who had the Veterans Administration, believe it or not, were the happiest with the care they got. So the Danish, who also adopted the Beveridge model after World War II, again for the same reason, they were equally devastated by the war, had less money than the British. And so they really began to focus on primary care as the infrastructure for their system of care. And if you look at the slide here, you can see that the UK system, their overall health system, is ranked about 14th in the world, 18th, looking at a slightly different model. And they spend about 7.7% of their total economy. We spend about 18% on our health care, so about significantly more than the British do. And our overall results are actually much poorer than England. We're number 37th in the world. We're between Costa Rica and Cuba. Now, this isn't if you have a need to get a kidney transplant. If that's the case and you have access to care, you probably get a good job, right? Probably as good as anywhere in the world. But this is looking at how well you're immunized, how well your colons are screened, how well you're managed and maintained overall, because that, in the essence, is really what creates length of life and reduces infant mortality and all the other indices, if that makes sense to you all. So in 2005, I reached out to the healthcare plans that served the Fortune 47, right? We had about 40,000 of those employees under Kaiser at the time, and we had about 200,000 under United, et cetera, right? And so as part of this process, I took Kaiser to Denmark to show them the Danish healthcare system, which I had the privilege of really supporting and working with as a healthcare ambassador for Denmark for years in their redesign. And what was really interesting was that everywhere we went, I would ask the citizens who their primary care doctor was, and they knew their names. They knew their names, and they would begin telling stories about them, right? They would say, my doctor is Gonzalez, and And that really impressed the guys at Kaiser. So we redesigned a clinic in Riverside and then Hawaii. And then if you belong to Kaiser now, if you have an emergency in the middle of the night and you call for help, you'll have your phone answered in Portland, Oregon. And they will answer the phone and they'll say, I see your doctor is Gonzalez. He would want us to care for you, and he will have this information tomorrow. So they try to pull everything back into the concept of who is your trusted healer, who's the person in your life that you can trust for overall care. And that model was really designed and developed by the Danes. So when we looked at the Danish system, we asked a fundamental question: how do you herd a cat? How do you create change? So there's only one way to herd a cat, and that's to move the food. So our fundamental plan and concept of changing how we delivered care in Denmark was to pay differently. So in Denmark, if you're a primary care physician, you're going to make more money than any other type of physician. And we're going to pay you differently. So we're going to pay you three ways. We're going to pay you per capitation. You can have as many as 2,000 patients in your practice. You have 2,001, you've got to hire another doctor and bring him in. We're going to pay you on how well you service your patients. So if you're answering your email in 24 hours, you're going to get less money than if you answer it in 20 minutes, right? We asked the citizens of the 98 communities in Denmark, there's 5 regions and 98 communities, we asked the citizens what they want of their primary care physician. They want access to parking. Okay. Yeah. They want relationship with trust. They want to communicate more effectively. So we designed a system to pay for that, and that's 1/3 of their income. So, in Denmark, if you call your physician at 10 o'clock in the evening, your physician most likely is going to answer the phone because he's going to get $50 for answering it. But if he wants to go on a date with his spouse, he just has to turn his phone off, and any other primary care physician in Denmark will take that call for him. And he'll say, because I've tried it, I sat with one of my employees in Copenhagen and I called at 10 o'clock at night, and this guy said, I'm Dr. Hans, I'm answering on behalf of Dr. Lars, your primary care physician, what can I do to help you? And, he had some funny liver abnormalities, which is normal, and the primary care physician said, oh, I see what's going on here, and I think you're okay, and by the way, your primary care physician will contact you in the morning. So it all rates right back to that. If you call an ambulance, the ambulance will go to your house, and chances are, rather than putting you in the ambulance, they'll do a video call with your primary care physician. So it's really linked in together. We reached a point where we now do about 93.7% of all care at the primary care level. We went from 120 hospitals down to 21. We think the last place somebody who's frail and elderly should be is in a hospital. So we provide, each of the 98 communities has responsibility for home care, for senior care, for childhood education, those kinds of services. So each of those communities has a senior center for those who cannot receive care at home any longer, in which the front of it is the community center. So that's where you get together to do your concerts, to do your plays, to do talks at the community level. The next layer around that is the senior center, where if you're well enough to take care of yourself, you'll live in an apartment, and each of your little patios will go outside on the thing. Behind that is the school. So the kids, when they finish school, they come out and hang out with grandma, and then the senior level above that is where you have hospital-like care for those who can no longer have the mental ability to care for themselves, et cetera. So it's self-contained in the community. But by and large, the community home service coordinates with the primary care physician. So if you're hospitalized for procedure or some sort of condition, the clinical pharmacist or the clinical nurse as part of your primary care team, will come to the hospital, take you home, go over all of your medication, make sure you have the right medication, and then guarantee that you'll be seen within 24 hours, or they'll follow up at home with your care. So we have the lowest medical error rate in the world, and probably the most satisfied customers. That system is funded by the federal government. So the federal government provides the funding for primary care. The 5 counties provide care for the hospital. So if you're working in one of the hospital systems in that county, you're salaried, just like you would be at Kaiser or the Veterans Administration. And you're ranked by an HR system that manages that. And then at the community level, the home health care. So those 3 systems, the federal government paying for primary care, paying for primary care physicians. If you elect not to have a primary care physician be the person who's providing you overall care, then you're charged 10% of total cost for your care. So you can go to a specialist in a hospital, but you're going to pay 10%. I think there's very few people that do that. They're pretty happy with the system of care. So we tried to, with the whole concept of the medical home model that we tried to evolve in the United States, we tried to learn from what the Danes had done, what the British had done, and develop a model in which we, the buyers of care, began to demand that. So we got all the healthcare plans in a room in Washington, D.C. in about 2005, and they all agreed to do pilots around this. But the head of WellPoint, Anthem, said, you're going to have to hold our feet to the fire, because we're going to ride in the wake of the other guy unless you all insist, as the buyer of care, that you. So they made a covenant with us. We did a press release in which they all agreed to do at least 3 pilots in 3 different states to collaborate with each other around this concept of care, or we would stop doing business with them, right? The Fortune 47. So about 6 months into this, United backed out, which was our largest carrier for our employees. I took them to the New York Times woodshed, right? And by 11 o'clock that morning, 14 of us had notified them that we weren't going to be buying their care any longer. And so John Engelhardt, who was then the editor of the New England Journal of Medicine, the Health Affairs, New England Journal of Medicine, did an editorial, and he said, Dr. Grundy is clearly not the father of this idea, because this really comes out of other parts of the world, but he is the godfather. So that's how I got the term godfather of patient-centered medical home. So the next model of care that is really germane to us. So the Beveridge model, in which the government owns and runs the hospitals, is our model of care for the Veterans Administration, Indian Health Service, military, et cetera. So the Douglas model was started in the prairies of Canada in the late 50s and early 60s. And the Douglas model is where the government is the payer of care, but they don't own and run the hospitals, right? So they just pay for the care at the hospital level. The Douglas model is run, in essence, a federal, state, province collaboration. And their overall rank of care, depending on how you look at it, is either 12th or 30th, and they spend about 10% of their GDP on health care. So when you talk about universal health care or single payer, these are the 2 models that really are single payer. One is single payer in the essence of the government pays your doctor to take care of you, and the other is the government pays a doctor, but isn't employed by them. So we adopted this model of care in 1965, and we called it the same thing that the Canadians did Medicare. We adopted it for those who were over 65. And the plan at the time was that that's all we could get. That's all that we could get through, right? And the deal with the devil at the time, in order to do that with the American Medical Association and the healthcare infrastructure, was we agreed to guarantee to pay prevailing rates. You can charge us whatever is prevailing rates, and we'll pay you, right? That's probably why we have the highest cost of healthcare in the world. But at any rate, so we adopted the Douglas model for those who are over 65. So in the United States, we have the Douglas model if you're over 65. We have the British model or the Beveridge model if you're a member of the Veterans Administration or Indian Health Service. The third model of care, and actually the earliest model of care, and in some part how the Flexner report was designed, comes out of Germany. At the same time, the Germans invented kindergarten, right, which is the name we still use. They also decided that they were going to pay health care for those who were employed. So they created a system of insurance where every citizen would pay a certain amount of their income earnings into an insurance model. Their employers would pay into an insurance model. And we sort of fell into that concept of care by accident in World War II. In World War II, we had a freeze on labor, and we had a lack of labor. So in order to attract employees, companies like Kaiser Shipbuilding and others said, we will pay for health care for you and your family, right? And that was really the creation of the insurance industry that exists today, right? So if you're lucky enough to be employed, and you're lucky enough to be employed by a company that agrees to have health care insurance for you as competition for getting your labor, then you have reasonable level of insurance. As you know, when we never succeeded in the original plan of health care for all by expanding Medicare down 10 years, 5 years each time, because we ran into roadblocks multiple times. We've had many, many, many attempts to circumvent the last model of care in the world, which is if you have money, you live, and if you don't, you die. We call that the third world model of care. In many parts of the world, you really don't have a system of care. You might have doctors that could care for you, but you've got to have the money to pay for them. And we reached a point where about 40 to 45 million of us were in that situation. We attempted many and multiple ways to get around that. We ultimately did something with that, with what became known as the Affordable Care Act, Obamacare, but was really Romney Care before that, right? It was the Massachusetts model under Governor Romney, where we created an ability to subsidize those who were not lucky enough to have an employer cover your care, weren't at 65, to have some sort of health care coverage. I was actually privileged enough to write a lot of the language of that Affordable Care Act. I sat in the Senate Finance Committee at the time. Both Grassley and Baucus had agreed to collaborate together. And then in the election, the Republicans decided there's nothing more frightening than changing health care. And they began saying government control, denial, and they walked off the court at the time. But we did create a model, a comprehensive care pilot design program to test changing primary care, to test what became known as managed Medicare, which is now about 40% of those who have Medicare now have some sort of managed Medicare. Kaiser, they're all ranked, by the way, by stars and how well they're actually delivered. I think in this region, the only one that has a 5-star is Kaiser.
Is that the Advantage program?
Medicare Advantage. known with multiple names, but an insurance company can offer that. This actually was taken from the Danish system. The Danish system follows the Kaiser model. The Danes, the Swiss, Central Europe healthcare plan. The Danes did something really interesting, really fascinating. They said, we're going to allow 10 healthcare companies to exist to offer healthcare plans, right? You're going to compete to be one of the 10. Now, in order to gain employees or citizens to service that, you've got to deliver a service that's exceptional and they're going to want. So the Dutch, they began this innovative model, which then the Taiwanese followed. But the Dutch, you had companies that would send doctors or nurses on motorcycles to visit your home. You had all kinds of different exciting models of delivery, particularly of primary care within the Dutch system, because the insurance companies were competing for your business, which was a very interesting model of care. So we overall ranked number 37, and we spend 15% of our GDP. This was in 2005. It's closer to 18 or 19% now for what we have. What's that?
Sorry, could you?
How much do we spend now?
Yeah, we spend about 18 or 19% now.
Yeah, if you want to ask a question, I'll pass the
Yeah,
microphone. I have one quick question.
Oh, you can ask questions anytime.
Thank you. Does this include drug costs?
Yes.
Yes, thank you.
We also, as part of the deal with the devil, we also agreed, prevailing rates, we also agreed that we would allow drug companies to charge whatever they wanted to charge. So we are in a situation where we oftentimes have 10, 12, 15, 20% higher costs than places. The Obama administration, or the current administration actually gotten legislation passed so that at least Medicare can negotiate for drug costs. And the Veterans Administration has always been able to negotiate for healthcare costs. But some of the drugs that are now pretty effective for diabetes control and weight control, I mean, they can cost $2,000 a month, right? So it's really very expensive. Costs $2,000 a month here, and it costs $80 a month in London. So the real disparity.
I have a friend that's being treated for schizophrenia, and it costs $2,000 a month.
Yeah, that's very
which
possible.
Means that she can't be on Medicaid unless she makes a very low wage in the marketplace. It reduces the amount of money she can make,
Yes,
for sustenance.
So in addition to Obamacare, where you can buy insurance if you can afford to buy insurance, we've had in our country a couple of other sort of what we call catchment systems of care for our citizens. One is Medicaid, and we agreed to expand that under the Affordable Care Act, but each state, under the Supreme Court decision, had the right to decide whether they were going to expand it or not. I think Virginia finally expanded it a couple of years ago. But the southern states, which have, by the way, have the worst indices of health care, many of them have not expanded Medicaid to cover more of their employees, of their folks by Medicaid. The other, in addition to being over 65 for Medicare, if you were old enough to remember when we developed dialysis and you saw these horrible things of people dying because they couldn't be dialyzed, right? Because they couldn't afford to be dialyzed. Medicare was expanded to include dialysis. So if you have end-stage renal disease and you need to be dialyzed, that's the other condition in which Medicare kicks in to provide care for you. We have a huge problem, unlike what the Danes did to sort out their senior care. We have a huge problem with long-term care and senior care in our country. That really needs a tremendous amount of sorting out. We have a lot of opportunities there, following up on the sermon from the day in terms of expanding care for long-term care. Yeah, we talked a bit about the Danish system already, but this is their design where they have at the center, they have primary care, and then around that primary care, they have a community that supports you. right? So I'm sitting in Funen Island in central Denmark, and the various not-for-profits, the various community services, the folks in government that are in charge of making sure you have heating and food and housing and all these other things, they sitting there chatting about, so the primary care community and the community care community gets together once a month and really looks across the whole spectrum of care, which includes social services as well as mental health services as well as health services, right? And so they sort of pull together the resources. And this one guy said, never again will we allow a diabetic to have an amputation because we haven't provided the care and follow-up to prevent that from occurring, right? And they have a 60% reduction in the amputation, right? 60% reduction in blindness compared to us, because the whole community is looking at the care of that patient in terms of adequate housing, adequate heating, adequate service, right? Yeah, pretty cool. Question?
So my question is, what does that...
Sorry, we need this for the video because it's being recorded, you see.
Sorry about that. What does the acronym PCMH represent?
Yeah, PCMH is the concept that I got known as the godfather of. That's called a patient-centered medical home. And interestingly enough, during the very early phases of the Obama administration, I was invited to the White House to talk about this with the Veterans Administration and government agencies and other folks. Nancy Ann DePaul, if you remember, was the person in charge of health care for the Obama administration. And she said, we don't want to call this patient-centered medical home because medical home equates to nursing home, doesn't work very well for seniors. The term comes out of pediatrics, by the way. It works well in pediatrics, but it doesn't work well in geriatrics. We want to call it high-touch primary care. That's what she said. We want to call it high-touch primary care. And I said, high-touch, high-touch. That was the name of the escort agency our governor got caught using, which is true. I was the governor of New York at the time, and he got thrown out of office for using prostitute service, which was named high-touch. So the Undersecretary for the Veterans Administration was sitting there, and he piped up and he said, we want to call it patient-aligned care teams. Yeah, so PACT is what they call it in the Veterans Administration, and it's a much better name than medical home. But the reason why we were kind of stuck with medical home was already in legislation. So, we were kind of stuck with that name, and it was legislation that came out of pediatrics. So really, we began to look at superb access to care, patient engagement in care, clinical information systems, care coordination. One of the other really important things that we began to look at, and when you look around the world, is benefit design, right? And what you want to do is create a benefit design in which you really incent the right behavior in the patient as well. And if if our employees, if they would engage in seeing their primary care doctor first, it was no cost, free. If they went to emergency room for something that wasn't an emergency, then they'd pay $250 out of their pocket before they got any care. So that's the concept of benefit redesign, and really trying to drive behavior both for the citizen and for the employee. And we evolved what was called the quadruple aim, which was a system of care where you not only look at the patient in front of you, but you look at your entire population. And in the medical home and in a healthcare advantage plan, you're rated on that, right? How well does the system that's caring for you follow up with you? How well do they remind you that you need your colonoscopies done? How well do they remind you you need your screening, et cetera? So, in these pilots that we started doing all those years ago, we reached a point where we had 35 or 40% of our employees, General Electric, right? And we began looking at the data. This is the data we saw. We really saw a significant drop in hospital care, a drop in ER use, inpatient specialty care is down, right? If you deliver comprehensive primary care as the foundation of a delivery system of value, in which the Danes, I think, were some of the earliest models of that, then you really see less need to have a hospital. Hence, that's the reason why the Danes went from over 100 down to 21 in their healthcare system. The Danes were really interesting in that they had, I think, 14 counties, and in order to, since the hospitals were run by the counties, in order to reduce the number of hospitals that weren't like the mega specialty hospitals, they, by legislation, had to change the number of counties. So they passed legislation going from 14 counties down to 5, so they could really focus on 5 areas of the country where they had the hospital training centers. And then each of those regions would have a super subspecialization. So in North Hunan, they would have super sophisticated transplant services. In another region, they would have super sophisticated neurosurgery, brain surgery, that sort of thing. So they really began to do that. The other thing that happened is we began the third payment for primary care that we designed was we wanted to keep the patient at the primary care level. So you got 3 payments. You got capitation, you got paid by how well you serviced your employees according to what how well you serviced your citizens by what they wanted. And the third was we gave them fee for services for those services that normally would go upstream in the system. And so if a primary care physician's office would learn how to and do colonoscopies in their office, right, they would get paid for that. So what evolved in Denmark is the primary care physicians began areas of focus that they were good at. Some would do sports medicine, and so they would refer among themselves for that level of care rather than sending them to a hospital for hospital care. So a hospital is really where you have a procedure done. It isn't where you house somebody who's senior, et cetera. I think I'm about finished. Yeah, that was it. Thoughts, questions, comments?
Thanks so much. So yes, we have time for questions. Please wait for the microphone.
I'm interested in your last point about in Denmark, care providers being incentivized to provide a care at the primary care level that would otherwise go to a more specialized level. And I can see that in the US would foster having every office own expensive equipment for diagnostic work or whatever.
Yeah.
And so it seems that works in Denmark partly because of the 5-county limitation on where the expensive equipment, how does that match up?
So that brings up a really wonderful point. We had a big transition in how we pay for care and how we're going to continue to pay for care, both from the employer's perspective and from the federal government. It used to be an arms race, to the point you're making. If I had a proton beam place and I could spend $2 billion to hire the best neurosurgeon, I would do that because that's how I would attract patients. Mm-hmm. You know, we now quote, pay for value. And so it's now no longer, it's not, you know, the hospital systems and the doctors are going to be continually rewarded for proactively managing a population and not, and so we've gone from a hospital system like Hopkins wanting to own every high-end procedure to a land grab. So they want to own as many lives as they can. So what you've seen happen in the last decade or so is that Hopkins is now spread all over. And you see consolidation of hospital systems occurring. And the reason for that is that payment increasingly is a significant part is per capita, right? Capitation, paying for value.
Payment here?
What? The federal government and increasingly employers driving their healthcare plans are trying to drive for value rather than for the high-end procedures. Yeah. Does that make sense to you?
Partly.
So the point you're making was to try to change the dynamics around it driving to that. You know, I'm gonna have the, so the primary care practices are increasingly rewarded more and more by how many lives they manage.
Seems to me that one of the big issues in the last elections in Great Britain was the terrible performance of the National Health Service.
Yes.
Huge waiting lists, employees complaining about no pay raises, et cetera. And one of the big complaints I know in the Canadian system is the same thing for lots of medical care, particularly, quote, optional, and that's somewhat in the patient's view, maybe not optional, that the waiting times are so long that they come to the United States to get their medical care. And I know from my own experience in dealing with both the DoD health system and the VA health system, the big problem is waiting times that it takes. And so to get rid of their long waiting lists, what they're doing now is, in essence, subcontracting back out to physicians who are not in their system. So I don't know how you solve that problem, but I'd like your thoughts on it, because it seems to me that that's a fundamental issue that so many countries are dealing with.
Yeah, so if you go back to Canadian model, for example, so they spend 9.6% of their total economy on healthcare. I don't think it's necessarily the fault of the system compared to the United States that you have a longer queue for the care you receive in some specialty care. It's that it's relatively underfunded compared to us, right? We're spending 18% of our GDP on healthcare. And we spend 18% basically for high-end healthcare rather than for managing primary care. I would say that if you're Canadian, you wouldn't want to change the system to ours. I think you're pretty happy with the fact that you're better managed, you get better primary care. You would probably like your government to spend a little bit more and fund it a little bit better so that you have adequate specialty care as well. And I think that's the case with the Veterans Administration as well. I mean, the Veterans Administration is significantly cheaper than per capita than it is for you as a senior under Medicare, if you have regular Medicare.
Yeah, I'm a bit surprised by your comment about that, because in the UK, if you can afford private healthcare, you get private healthcare. And it's true there are long waiting lists in the national health system for people who don't have a private healthcare system. But if you can afford to come to America and pay for...
But by the way, you're still going to go to your GP for your primary care, even if you have private health insurance for special care.
But your point is exactly right. And it's the same thing in Canada. If you work for some companies, you can get private health care, and so you then use it to come to the United States. I think that, so you've got the same thing in the United Kingdom. If you can afford it by whatever means, whether your company pays for it or you pay for it, then you can go to a private physician and go overseas and get it. So, by the way, I'm not advocating that we keep our
I understand.
system,
Yeah,
but
no,
it seems to me that
each system has its problems as well as its good points. I mean, there are issues, ups and downs. I'm just explaining. And by the way, we have all those systems here. We just matter where you live what you get.
I have read that people spend half of the money that they in a lifetime for medical care. That in the last year of life, you end up spending half of your total lifetime medical cost for the last year. Have you ever seen a statistic on
Yeah.
that? And what do you say about it?
There's a joke about that I'll start with, and that is, you know, to the Scotsman, life is dour. Life's going to end, you know. You know, to the Englishman, you know, death is inevitable. To the American, death is an option. I think, you know, I studied that intently, looking at that issue, specifically that issue. Gunderson in La Crosse, Wisconsin, happens to have the best reputation for everybody having a living will. The societies, the churches, the community, the fire station, they're all involved as a community in making sure that everybody has a living will. And I visited hospital at Gunderson, and I was so impressed because everybody in the intensive care unit there had the hope of living, right? There was an expectation that they were going to live on the part of the staff and the faculty. I went up the street to Milwaukee, Wisconsin, and I visited a large hospital system there. And half of the people in the intensive care unit were being milked while they died. There was a 98-year-old, stage 7 Alzheimer's that was being tube fed. You know, I mean, a lot of our expense is that we have this sense that death is an option. You know, in our culture and the expectations in our healthcare delivery system. And, you know, we should be evaluating what good we're doing at end of life. And if it's not doing any good, we shouldn't be doing it. But boy, we don't have any control over that at all. We have the right, you know, it's just, but, you know, in a system where you really have a living will, where you really understand what your options are, you know, we did a big study of physicians in terms of how they wanted to die, and it's much different. The expectation, they don't want high end, they don't want all this stuff done for them at end of life. Yeah, I mean, it's the quality of life, not longevity of life. Does that make sense to everybody?
Have you done any research on the satisfaction of the providers, the doctors and nurses in some of this work you've done?
Yeah, absolutely, yeah. Again, when I was at IBM, we would survey all of our patients in terms of their satisfaction and looking at where they got their care and how satisfied they were with the care that they got. And then we would ask them what they want. We did a 3-day jam of all of our employees around healthcare. What do you want for your healthcare? We're helping you buy it, and we're buying you the wrong thing. What would you like us to do? It was interesting. It was some of the same things that came up in Denmark. They wanted adequate parking. But, you know, they wanted a relationship of trust. They wanted better communication. We weren't giving them any of that, right? None of that.
My question was related to the provider's satisfaction, the doctors and nurses giving the care. Have you looked at their satisfaction?
Yeah, I have. One of my friends was a guy named Jeremy Hunt, who was the Secretary of State for Health for England, and I used to tell him that the Australians love you because all the doctors were leaving, going to Australia. They were burning them out very, very quickly in primary care. We tried to do something about that, although we weren't successful. But we have a higher suicide rate among our physicians in the United States than we do almost any other population. I sat on the board that oversees our residency training, ACGME, for 10 years, and one of the things we really looked at was that kind of issue. You know, what are we doing to people who go into medicine? It's an issue. The highest burnout rate we have is our emergency physicians. We look at that every year in terms of in terms of physician satisfaction.
About drugs, I've been struck by the number of medical adverts on TV for drugs. Ask your physician about this. Ask your physician.
Yeah.
The physicians should know what drugs you take. And
Well,
don't say, I saw it on TV, give me this. I mean, why do they do this? Well,
By the way, that was another Supreme Court decision that allowed that to happen, all those advertisements. Questions? We have a couple of questions.
2 more questions, 2 and 3.
Carol?
Paul, would you agree that the best systems are better at using a preventative approach towards healthcare rather than a for-profit and disease-oriented model?
Yeah. We have what we call an upside-down pyramid in the United States. You know, what you should have is a pyramid in which the bottom is preventive medicine, primary care, and then specialty care. Ours is opposite. Ours, the funding is as in specialty care, and then the last funding is in preventive care. You know, that's why legislation that occurred with the Affordable Care Act, including stuff like silver sneakers and, you know, trying to get more preventive things included in the health in Medicare, right? Because the government controls the payment around that. So yeah, absolutely. We have it upside down.
One more question, and then we'll wrap up.
So you've talked about rankings for health attainment, and it sounds like the system in Denmark that you've described is high in that parameter, and that Medicare and, VA and Indian Health Service are closest to implementing something like that?
VA and Indian Health Service, yes, to some extent, I would say. The best model I've seen in the Indian Health Service was studying the ones in Central Alaska. It really fascinating, you know, what they've done. They've taken their prevention back to their basic culture. What we found there was these folks don't exercise, but they dance.
Right.
So they created dance classes where the grandmas and the kids would dance together, and that turns out to be pretty good exercise. I mean, you know, sort of looking at the cultural aspects of how you get people to actually do what's right for them to do.
My question is, and for those in the U.S. who are not yet Medicare eligible, one of the models of care is more the HMO, like Kaiser.
Yes.
And it seems to me from your description today that Kaiser is more akin to the Denmark system than,
and it's for the same,
than a PPO kind of plan.
So and it's for the same reason to some extent, right? We you know, a head in a bed is a profit under the old system of care, the pre-Medicare Advantage system of care, right? So you're going to be looked at very differently if you have a PPO plan or one in which, you know, than you are in Kaiser, where a bed in a bed is a cost. Yeah, so it's trying to flip it on its head. So increasingly, Medicare is driving towards no longer paying PPO, no longer paying for procedures, but paying for you to be managed by a system of care. Yeah. And they swear, although it will depend a lot, I think, on who's elected, they swear that by 2035 that all Medicare will be capitated, will be in a butt in a bed is going to be a cost to the hospital, not a profit.
Well, thanks very much for that. It was very fascinating. Thank you. Another thing, it seems, is in the UK, we just had a change of government, as you may know, and two big issues: a healthcare system, which is sort of broken down, and the prison system. And that would be an interesting topic for another thing, about a prison system in America, where we lock people up for sometimes trivial things that cost great amounts of money. And I know in Scandinavian countries, they don't. They have more of a reform. They want to reform you, and they don't lock you away in prison to punish you for 20 years when they can get you out in 5 years to be a better citizen. Anyway, that's a subject. If you know somebody who wants to talk about that, Thank you. All right, bye. See you next month.